one of the telecleft lecture series, which have been on since January. And so today is just one of such that have been given at one time or the other. The lecture has its objectives, and it is guided by the mission and the vision of the telecleft series. The aim of the telecleft series is to educate and update knowledge about cleft lip and palate in Africa. Lecture will focus on presenting management of a Nigerian child affected with cleft lip and palate from birth until adolescent. The management will consider in two parts: before surgery and after surgery, and then the challenges we have with orthodontic treatment, summary and recommendation. So that's the Nigerian child with a cleft, the typical presentation that we have in our clinics. So concerning cleft lip, we know it's a congenital malformation, and sometimes it can present just like a slit on the lip, and it extends onto the palate. And the problem is that it is impossible to close this without some form of surgery. And perhaps the reason why we have Smile Train today, they focus on sponsoring free surgery and the management of such children. They've been in Nigeria for some time now, and I think one of the reasons why we can have this lecture as well. Yeah, concerning prevalence, it is reported that we have 1 in 700 generally of live births. So every 700 children born on earth, there is likely to be one with a cleft. But of course, that varies in population. And so in Nigeria, we have a low prevalence as compared to the general one. And 0.5 per 1,000 have been reported. Problems associated with having cleft. We know that at birth, we could have feeding problems because, of course, you know, the cleft is like a hole. It doesn't allow good sucking. We could have breathing problems in the case of where the child is not able to close the mouth properly. We can have psychological and emotional problems, and these are usually associated with the fact that, you know, people think this child is not normal. Why me? And then we can have aesthetic problems that is due to the fact that in Nigeria here, we have naming ceremonies on the 8th day after birth, and then you want to bring out this child and, you know, show the cleft, and people are wondering what's wrong. So this could be, you know, initial problems associated. But of course, we are talking about orthodontic management today. And so we are more concerned about what could go wrong inside the mouth. One of it is that we can have an underdeveloped maxilla. Remember, the cleft itself is like a break in your upper jaw, in the maxilla. So you don't get the growth, just like if the cleft wasn't there. You could have missing or peg-shaped laterals. You could have what we call a crossbite, supernumeraries, crowding of the dentition, rotated teeth, impacted teeth, and of course is increased susceptibility to caries and periodontal problems. That's because, you know, the teeth might not be well set and might create you know, gum problems for the child. So in Nigeria, you know, generally, what we aim to do is to see if anything can be done in the first few days of life after birth, especially if the pediatrician thinks they may benefit from appliance therapy. History checking gives a better understanding of what has been done so far in the course of management and help us to know what are the concerns of the affected person and parents and guardians, and if there are any medical problems or associated syndromes. And this is important because we are talking of orthodontic management, but we don't want to rush at just managing without knowing what is the background to this. So we approach it in 2 stages. We have the pre-surgical and we have the post-surgical. And of course, pre-surgical means before surgery. Is there anything that can be done for this child? And post-surgical is after surgery. What do we do? So in time past, in our clinic, we made an attempt to construct NASO-ALVEOLA molding appliances or feeding plates for affected children that were referred to us. But the referral from the GP or the pediatricians may have requested some form of intervention based largely on problems with feeding that they observed in the children. But with advancement in technology, we'd hardly get this reference anymore, because somehow maybe the feeding bottle or maybe the surgeons or the pediatricians are just not referring them, so it's not as common as before. But if you talk of a NASO-ALVEOLA molding appliance, that is typical of what you will see. This will be placed in the patient's mouth at one time or the other, and that can help with the molding. So I wouldn't stay too much on that, because it's a stage that has to be considered carefully, and maybe studies to prove, is there a difference with NASO-ALVEOLA molding before surgery or not? So a lot of evidence needs to be confirmed to continue management as orthodontists on that. However, for post-surgical orthodontic management, which is the one I'm dwelling on more, it can be considered in different stages. We all know that we have deciduous dentition stage. We have what we call the mixed dentition stage. We have the permanent dentition, and we have, of course, an adult stage where the permanent teeth are out, the patient has stopped growing, and so what can be done at this stage? I will start by saying successful management, like it is in every form of treatment, whether orthodontics, whether basic dentistry, whether medical, you all need a good history, a good clinical examination. You need to do investigations, and you need the skill and experience of the clinician. So in Nigeria, what we have done so far, or what I think I have done at one time or the other, is that we can see the child with cleft at the age 6 to 12 months. During that time, we do what we call oral examination of the erupting deciduous teeth and counsel on the care. The parents usually have questions. This is the stage the first teeth are coming out at the age of 6 months, at the age of 5 months plus, and they're just concerned, and so we are able to also refer them after that. We do the lip repair, because it's usually done in stages. The surgeon does the lip repair, but they leave the palate until the time they're about to, to speak, so that they could incorporate, the palatal repair in a way that the speech will not be affected too much. So we then say, okay, we refer to the surgeons for palatal repair. And we do recommend that orthodontists do this, because somehow they come in as a middleman in the whole thing. So they are able to follow this child along with the journey. Hello? Hello? Oh, I'm just talking. Hello? Oh no, what's happening?
Prof, please continue, you're fine.
Oh, okay, sorry. I just need to know that people are listening to me. Okay, thank you. So we have 6 to 12 months, And that is after the lip repair. Okay, so we have 3 to 6 years. And in that case, the orthodontist can help with guidance of eruption. They can reduce the severity of malocclusion. They can also use removable appliances for expansion, and that will actually help in establishing an overbite in the growing dentition. We also have at the age of 7 to 9 years, where we can do approximation of the upper central incisors. We can use a removable appliance to do that. And we can create space for eruption of the maxillary canines. Also, at the age of 9 to 11 years, that is the time we're talking about bone grafting. Bone grafting actually done by maxillofacial surgeons, but then we also have that opportunity to be able to recommend and refer these patients at that age. That is an example of a palatal expander, and you can see it right there in the maxilla with the hope that it will make the underdeveloped maxilla expand a bit more, especially in a growing child. So those are the things we could do: decidual stage, mixed dentition stage. I've talked about them. But at the definitive orthodontic treatment, that is the time all permanent teeth have erupted. Well, of course, with the exception of the wisdom teeth. We all know that the third molars can come in, at 21 or thereabout, or sometimes 18. So we won't wait until that time. But once we have the first, the 1 to 7, that is the second molar and all the incisors run through down, we can start our treatment. At this stage, we have clinical examination and investigations carried out to aid diagnosis and treatment planning. So such radiographs as the orthopantomogram and the cephalometric x-rays are necessary for that. For the OPG, we need to ascertain that there are no impacted teeth or unerupted supernumeraries, and also to be sure of the position of the last molars, because that could lead to secondary crowding. So if they are impacted or they are going to impact on the treatment later, we might as well recommend the extraction. Now, a clinical examination is key to what we have. And I tried to put this, it's not too clear as I can see, it's a snapshot. But basically, we do have a sheet we can use to examine. And in that sheet, we have all the parameters that has to do with the oral health tissue, the teeth itself, the present teeth, the absent teeth, the jaw relationships, the soft tissue relationships, the radiographic reports, and then we then come in with a summary at the end of the day. We can even do the IOTN, that is the Index of Orthodontic Treatment Need classifications, or, and then, we'll be able to recommend and this patient for treatment. I can tell you that in cleft children, the IOTN usually, it's always on the side of a great need for treatment. Okay, so that's like a comprehensive sheet, to like a data recording sheet for the patient. And then we have OPG, that's how it looks like. For medical colleagues coming in that may not be very familiar, it's just basically spreading out our jaw right to left on a horizontal plane. So that gives us an idea of all the teeth present, of all the teeth buried. As you can see here, there's some buried teeth somewhere here. And that gives us a dental age of this patient. I would say, because this is like the 6 impacted somewhere, probably the patient is just about 6 years, almost 6 years, 5.5 years. So those are parameters that we can use to examine our cleft patient. We do know that cephalometric x-rays are things we also use for these patients. What we are interested in a cephalometric x-ray is more like looking at certain angles. We have what we call the AMB. Sorry, this is actually a mistake. This is the SNA angle. I will correct that in my slide later. This is the SNA angle, and that just gives us the degree of proclination of the maxilla in relationship to the mandible. Usually, in patients with cleft, you have a reduced angle from the norm, and that's because the maxilla is usually underdeveloped. So we have the SNB. That's also a mistake. I think that was just a typographical error. This is the SNB angle, and that has to do with the degree relationship of the mandible to the maxilla, and coming in to say that the mandible usually is normal in this patient, but the maxilla is the one that has a reduced proclination. And then we have the proper AMB, which helps us to know the degree of skeletal discrepancy in the maxilla and the mandible. And so a normal AMB angle would actually be 2 to 4 degrees, okay? Well, in other children, cleft children, we have it less than 2 degrees. This is actually the S line, so I will take that off now. Okay, so another thing with cleft lip and palate may be a reduced facial height. You can see a typical cephalometric X-ray showing the lateral view of the skull. In patients with cleft, we have what we call a reduced facial height, and that is after we've done our analysis like this. And reason for that is because we said the maxilla can be underdeveloped while the mandible is normal. So that means you are having a reduction in one of the jaws as compared to the other, and can cause a reduction in your facial height. We are taking all this into recognition and importance and record because they play a role when we are managing such patients. We've mentioned that the OPG, which is the orthopantomogram, actually confirms the presence or the absence of supernumeraries in the mouth. It also determines the position of the wisdom tooth, which are the third molars. And if they are impacted, they may cause secondary crowding. So we recommend their removal before starting orthodontic treatment. The cephalometric X-ray, on the other hand, is used to assess skeletal and soft tissue parameters for the patient before treatment. And so it's good to mention, I think I've done that on the table, that bone grafting is a good thing that helps with treatment, especially because the maxillary canine are yet maybe to erupt at the age of 9 to 11. And so when we do bone grafting, it actually helps with eruption. Okay, so when we have done our investigations, we then want to look at how to treat this malocclusion and to correct aesthetic problems. It's usually helpful to create a problem list, and so that our treatment aim will achieve this purpose. We want to ask parents if the patients are minor, and the patients themselves if they are adults. We want them to tell us what they feel is wrong with their teeth. Okay, and that's key and important because it kind of gives you an idea of what you really need to do. Remember that when surgery has been done, it does create, a minimal scar, which is on the lip. Patient can see from outside. Sometimes it's almost not visible, except you move close to the patient. So the patient may not be talking about the scar on the lip. It might just be the intraoral presentation, the way the lips are. Sometimes it's speech problem. And so we as orthodontists need to be able to examine, generate our problem list. So when we generate the problem list, of which I will be doing later, I will show a typical, okay, maybe I'll try and go to that problem list. Okay, so now this is a typical, I'll go back to the next two slides, a typical intraoral presentation. As we can see in this one, we have the upper, that's the one on the left now, that's to my right. In retroclination, okay, we have the peg-shaped laterals, and we have a crossbite. Now, if you look at the patient from outside, it probably would just be a normal lip with a scar, minimal scar, but the intraoral presentation gives it out to say perhaps there have been a cleft of the palate as well. And that is the palate. You can see the one, obviously not in line with the other one. The one on the left side is not in alignment with the one on the right side. You can see the peg-shaped lateral on the affected side as different to the normal lateral incisors, I mean, that is the second tooth. You can see different on the other side. You can see the rotated, that is the first premolar, no, the fifth, the second premolar, that's the 5. And you have a missing 4. It's probably somewhere there, just palatal to the canine. So this side is obviously have been affected by the cleft, and that is the typical presentation we do get in the clinic. Look at the lower jaw of this patient, and the lower jaw gives us the idea that this is a normal jaw, but the upper jaw shows us that something had gone wrong at one time or the other. Hello? Am I on to somebody?
Go on.
Okay, thank you. Just want to be sure. Okay, so we do have on the cleft side now, as we can see here, retroclined, the right, the central incisors. We have the peg-shaped lateral, and we have the rotated, actually the second premolar, not the first premolar. That will be corrected in the last slide. And look at the non-cleft side. Beautiful presentation, having the canines in occlusion, that is between the upper canine sitting in the embrasure, between the lower canine and the first premolar. We have the normal laterals, they are not peg-shaped. We have the normal overjet there, even though the overbite is reduced. We have it showing more of the lower incisors than the upper incisors. And we have an Angus class 1 malocclusion on the non-cleft side. So when we compare the cleft side with the non-cleft side, we can see that it is obvious that having a cleft does affect the intraoral presentation. It affects the teeth as well as the size of the teeth. because this is the same patient. So we have the same patient having a peck-shaped lateral on this, that is a smaller tooth on the size of the cleft, and having a normal lateral that is on the non-cleft side. We have the same patient having a rotated premolar, and on the normal cleft side, the premolar is not rotated. Same patient having crossbite on the cleft side, and on the non-cleft side, no crossbite. It is obvious that the cleft, which if we look carefully between the 1 and 2, you can see that dent, indentation there. That is obviously where the cleft had been, that was repaired, on the palate. And you can see here, this is normal, where full. You have a fullness of the alveolar bone here as compared to the cleft side. Okay. So, so in basically, we then want to go to fixed appliance. I will go to the former slides I was going to talk about. Okay, so fixed appliance therapy, we are interested in the correction of malocclusion, and we said it's been done with brackets and wire, which I will show you. We are aiming at achieving a normal overjet and a normal overbite, for the fixed appliance. So I will go in and then show them. Okay, so in the fixed appliance now, we put on the brackets for this patient, and the aim, of course, is to try and correct the anomalies we did list out initially. Fixed appliance works better when we are able to attach them fixed onto the teeth. The wire actually plays the role of moving the teeth, but then they need to be secured, and that's why you're looking at the elastics that are showing in here as the ones tying in the wire onto the brackets. Now, these brackets, these little attachments you're seeing, are fixed on with the aid of some cement, which we use, a kind of glue that makes them not removable. They are part of the dentition, so to say, of the patient for the period of treatment. They are, going to be eaten with it, brushing with it, talking with it, and doing every other thing they need to do with them on. Treatment actually for this set of patients can last just about sometimes 24 months, 18 months, or even more. So this patient has to put on this fixed appliance for that period of time. It can be uncomfortable sometimes because it's not part of the dentition, and but then over time they get used to it. They are told this is what is going to make your treatment work, and so they are committed to ensuring that they keep it in their mouth, so that the treatment can work. Orthodontists are trained to fit brackets on the teeth, and that is why they play a major role in the treatment and management of children with cleft lip. Because aside from the cleft itself, which can be repaired by surgeons, the teeth needs to be, reset, so to say, in layman's style, or corrected so that the children can have a functional, or the adult affected can have a functional occlusion, meaning that even if the soft tissue is repaired and the teeth are not functional, the children may still have a reminder of the cleft. So holistic care actually aims at giving the child, holistic care, which means we are not just talking about repairing, which is not my scope. We're not just talking about speech, which is not my scope. We are talking of a functional occlusion and a pleasing and aesthetic appearance, which is my scope. And that is why whenever these children are affected, we just don't wait on their repair alone or their speech alone. We also intervene by correcting their occlusion. So we discover that some of the children, depending on the severity of the cleft, may have skeletal discrepancy that is severe, meaning that syndromic, there are some syndromes where the cleft on its own has other forms like underdeveloped mandible. In a case like that, orthodontic treatment may not suffice. So we do recommend orthognatic surgery as a treatment of choice. Orthognatic surgery in itself is in the scope of maxillofacial surgeons, but they work in hand as a team with orthodontists. Remember that we talked about investigations, cephalometric norms, cephalometric parameters that will be needed for the surgeon to have a successful surgery with this patient. So when we examine, investigate, and come to a diagnosis for certain children who have severe skeletal discrepancy, then the choice for them will be orthognatic surgery. Basically, it corrects the skeletal discrepancy, just like surgery. That means let's just cut the bone. Let us oppose them together and let it work. So I wouldn't be talking too much about orthodontic surgery because, like I said, it's within the scope of the maxillofacial surgeon. But if another time permits, there are things we can always talk about hand in hand as a team. Okay, so I come to a major aspect of this particular topic, which is the challenges with orthodontic management of children affected. So far, we did try to talk about their management. We did try to say, which I will do in my summary anyway. But let's say that the treatment itself is a journey. It is time consuming. It is capital intensive. Time consuming because there are so many visits. The mother or the parents or the guardian has to take the child through. On the table, I showed initially, we talk about coming 6 to 12 months. We talked about coming 3 to 6 months. We talked about coming 6 to 12 years. or 13 years, we talked about coming. After the permanent teeth have erupted, we talk about coming as an adult. They are milestones, and they are, they could be stressful. So one of the problems we then have is that, some parents find it a daunting task, and they're just concerned and happy that the cleft has been repaired. Okay, so we then have to convince them that yes, the cleft has been repaired, but your child is still not having a functional and a pleasing and aesthetic pleasing occlusion. If he opens his mouth, he's going to be reminded of this cleft, which surgery has made it, maybe with good sutures, almost invisible for people to know. But once he opens his mouth, you're going to see the cleft, because the teeth are a reminder. The way the teeth are set in crossbite, if they are rotated, if they don't have a good overbite, there will be a reminder. So we then work on the parents in terms of follow-up to try and make sure the patients actually attend clinics. So that is a major challenge, making the patients to come after treatment. Remember, there is also, a gap between the time the repair is done and the time they won't have their permanent teeth. So I'll be talking about recommendations on how we can overcome that in my recommendations later. So we said that relapse is also a problem. And I think one of the ways we can overcome relapse is to do permanent retention for the patients. This is in a case where we have corrected the malocclusion. The patient already has a normal overjet, they have a normal overbite, but we are not going to leave them down to that. We do know that there is a problem in the fact that the tissues for a cleft child is already compromised. Compromised because, the cleft created a gap in the width and the length of the maxilla. So surgery actually stretched over that tissue, to close. So when we do orthodontic treatment, we're likely to have a relapse because the tissues, the scar tissue, the compromised tissue are going to try and pull back the teeth that have been corrected. So a way to get over that, is to give the patients retainer, and in this case, permanent retainers to overcome the problem. So in summary, because I don't have too much time now, I have just 4 minutes more, is to say that management of these children can be regarded as a journey, and if well planned and the protocol followed, it will be successful. The lecture actually highlighted the current orthodontic management protocol for Nigerian children, which is the table I gave, and that is to say at 6 to 12 months, we can see them, advise, counsel, and refer them for palatal repair. We can guide eruption. We also said that at 3 to 6 years, we can expand the maxilla because they're still growing. That can be helpful. 6 to 12 years, we can do a lot of things, help them correct overbite, crossbite, and we can also do bone grafting. So then later in the years, we can be definitive. Usually it's fixed appliance. Now we say orthodontic treatment requires expertise, skill, and equipment. And that is why the surgeons, when they finish their treatment, they are mindful to say we have not completed care for this patient, and they do refer where they are supposed to refer to orthodontists for us to continue. We say the ability to diagnose correctly using all available diagnostic aids is important. There are so many diagnostic aids. The 45 minutes lecture, you might not be able to finish all that. And then we say, for what I know, sponsorship of orthodontic treatment has been made available with the Smile Train funding. So that should not be a problem now. The problem more should be to get the patients to come for treatment. I'm making some recommendations, and that is to say, ability to monitor this child from birth to through the treatment journey. Remember, I did say one of the problems is the loss follow-up, because, well, for whatever reason, the parents are happy with the repair and they don't bother much about, the occlusion. And that is, of course, because most of the children affected are from low socioeconomic class, so they might just feel it's a luxury taking care of their teeth. So I make recommendation as an orthodontist, never mind the S, that will be edited later. An orthodontist should be able to play the middleman role. That is, they can manage these children at different stages. A recommendation is to use private clinics as monitoring center for the children. What I mean by that is paying retention fees is very important, because private clinics are profit orientated. And so when they are paid retention fees, say, oh, okay, we want to adopt your clinic to be a middleman as a monitoring, a help for cleft children. Once they get surgery, you monitor them through the journey, through their journey stages. We might be able to retain more patients that way and, have holistic care. The use of university healthcare centers for orthodontic treatment. When I was preparing this, it occurred to me, every university has a healthcare system. And normally, you see staff and you see students. But because you need to monitor cleft children, you discover that students can be used as ambassadors for propagating Smile Train sponsorships. In this place, a Smile Train creates a monitoring center or a treatment center, an orthodontic treatment center. In a university healthcare center, you might be able to use students as ambassadors to help in monitoring. So these are some of the recommendations I've made. I can't see the third one now, but I think basically it is to, encourage Smile Train to continue to sponsor orthodontic treatment and equip centers so that they can, be able to offer care to these patients. So some of the references I used. Thanks for listening. So it's 45 minutes now, and then I will stop my lecture here. Thank you.
Thank you, Dr. Adeyemi, Dr. Tokunbo Adeyemi, for this very interesting lecture on orthodontic management of the cleft lip and palate patient. I think we'll go ahead now and entertain some questions. There are some questions in the Q&A box. The first question is from Rudolph Diop, and it says, cost of orthodontic treatment is a huge constraint. What is the cost of such treatment, and how do you deal with it? So maybe you take that one. He has the second question. So maybe when you finish with that, we'll go on to the second one. Thank you.
Okay, thank you very much. That's a good one. Cost can be a major issue when it comes to orthodontic treatment. But I did mention that SmileTrain offers sponsorship for orthodontic treatment. I would say that there is a range there's a variation in price and in range. And for what I know, currently in Nigeria, in teaching hospital, which will give possibly the lowest cost of care, we have approximately $500, I would say US dollars, what we call 250,000 is 500 US dollars to offer orthodontic treatment to a child, a cleft lip and palate child that needs it. However, what I believe SmileTrain is trying to do is to offer, maybe either in terms of partnership or having their own clinic, so to say, because Dr. Folanomi, I think she's doing something in Enugu. She shared with us that SmileTrain equipped the clinic, the instruments, the armamentarium, and so basically it probably would be to pay the clinician their own fee, which can be negotiated. So if the materials are available and it's just a clinician fee, I believe that could go down a bit, but I wouldn't know what they actually pay for each patient. I'm not aware of that. So that's a way to overcome cost because it could be sponsored. And so that means the patient will not need to pay. So that's not an issue for the patient for now. I hope I answered that question. Hello?
Thank you, Dr. Adeyemi. Yes, thank you, Dr. Adeyemi. Yes, I think you have appropriately answered the question. So we'll go on to the second question, which is from the same Rudolph Diop. And I want to believe that we have translations going on as we are going through the session. And his question is, what explains that most patients are lost to follow up? What explains that most patients are lost to follow up?
Sorry, say that again. I didn't get that. What?
Well, let me rephrase it. How do you explain that most patients, why is it that most patients are lost to follow up? That is the question. Why? Why are they lost to follow up? Yes. In your own
okay, thank
assessment.
you very much.
Yes.
Yeah, thank you very much. I did mention one, okay, the fact that, they are just happy with the repair and they don't want to go through the stress of coming all the time, bringing the child, because it could be a journey, like I said. At each stage of life, you need to bring the child for this, for that, for that. But once the repair is done and the parents feel, oh, this is fine enough, they can, overlook, especially because they are usually from the low socioeconomic class and they count it a luxury, to have teeth that are well set or aesthetic pleasing. But again, I think there's also a problem with, teamwork. Like I said and I'm making recommendations, an orthodontist can play the role of a middleman, meaning that from the beginning, when this child is seen, they stand in as monitoring agents. Because what we currently have and why we do have a loss in the follow-up is, is that we have the surgeon, treating the patient, keeping the records, and then that's it. They follow up and, the deed is done. They've done their job. they've done surgery, which is what they are called to do, and they manage the clinic. And so that means they just, give the patient's appointment for review. But when the patient starts growing the dentition, the child may not need to come for a review, because the review will be post-surgical, maybe 3 months, 6 months, and they are done. So the orthodontist now starts his own job when the teeth actually comes up. But the child has been seen in surgery and has completed what he needs to do. So we then have a problem of how do we get the record of that child, except the child comes in. But if an orthodontist is a middleman, meaning that you come into action or role play when exactly the patient is seen in the first instance. So you then have the records, the telephone number, the address, and the contact, so then it's easy to follow up. So if I will summarize, why we lose them to follow up is that, sometimes they may leave wrong address, sometimes they may have changed their mobile number, sometimes you don't even know where to get them, and sometimes the records are missing, and then the surgeon has finished his work, so he's not really bothered about, following them up after a period of time. So
thank you.
I think that's, yeah.
Thank you very much for that response. We still have another question from Gaetan Shaka Mapoli. I think this is in French. And Emily, is there any translation for that? This is in French.
Yes, I can help with that.
Okay,
in
please.
French, the person is saying, la sensibilisation demeurant un défi, quelle stratégie prendre pour y remédier? He says, awareness remains a challenge. What strategy to adopt to address it?
Okay, thank you very much. Yes, awareness continues to be a challenge, but I made some recommendations. Remember, I'm talking about orthodontic management. I can also put that in to say that having ambassadors, okay, whatever people know what you're doing. So Smile Train can decide to adopt ambassadors using middlemen, using covering of people that they feel can help them administer in terms of advertise rather what they are doing. So that means you are recruiting people who are, passing on the message. This is possible. This is available. Smile Train offers free surgery. Smile Train can sponsor orthodontic treatment. They need to know. It has to get around. So one of it is, getting ambassadors. Another one is doing radio programs, radio programs on a consistent basis, whereby, this is called a Smile Train program. So they know X day, Tuesday, Monday, or whichever day you choose, 9:30 to 10, there is a program on. The people are coming in, asking questions, getting to the grassroots. It could usually be in the local language. For instance, we speak Yoruba here. We have radio stations, television stations that are in the local language that can get across to people with this problem. And of course, this telecleft lecture series is part of it anyway. The only problem with this is it goes to the elite, it goes to the informed people, and maybe they can just get to know more about what we are doing.
Thank you. Thank you, Dr. Adeyemi. I think that's some useful information for Smile Train going forward. We still have another question. Because of time, we'll go to that question. Can we still get some help, Nicole, with the second question from Gaetan?
Yes, sure. Based on your experience, what would be the average treatment time given the complexity of the cases? And what is the minimum equipment needed to conduct the treatment?
Okay, thank you very much. I will start from the last question, which says, I mean, what is the minimum needed? Well, minimum is having a cephalometric X-ray, an OPG, and no, it's usually a combined. That is, that gives you records. You need records for every patient. You need investigation for every patient. So you need to have a functioning OPG Cleft radiographic machine. You need to have a dental chair that is functional, because positioning also affects your treatment, you know, the way you position your patient. You also need to have basic hand instruments, a good light source, a good camera, because that's the only way you can justify what you're doing. Taking pre-op photographs, taking post-op photographs.
Thank you, Dr. Adeyemi.
So,
I think you have, yes, you have answered the question, because we're running out of time. We thank you very much for the question. I don't think there are any more questions in the Q&A box. Okay, I think there's still another one from Professor Ayub Ali. He says, what percentage of cleft patients need orthodontic treatment? What percentage of cleft patients need orthodontic treatment in your own assessment?
Okay, thank you very much. It's also a good question. I would say once the patient has a cleft lip and palate, they all need treatment, because treatment itself is not just the fixed appliance. Like we said, there are different things you could do. It could just be to guide onto eruption. It could be to bone graft. It could also just be, you know, to correct crossbite. It could be to mask a peg-shaped lateral. So every child with a cleft palate needs treatment. But the ones with cleft lip alone without palate may not need treatment, depending.
Okay, thank you. Thank you very much, Dr. Adeyemi. I just want to also add my own question. What, in your own assessment, is the way forward in improving collaboration, from what you have said, in amongst specialists, especially in a teaching hospital, being that we have this challenge of loss to follow up, etc., etc. What, in your own assessment, can make the difference going forward?
Okay, yes. So one of it, like I had mentioned, is having what we call ambassadors or middlemen, but they have to be retained. Nothing really works without, you know, a kind of gratification in this system. So you have those who are either middlemen or ambassadors who actually, they could be specialists, but their role is to mediate through the journey. So they know this is the, like each center has an ambassador. This is the work I've been employed to do. You know, I'm being paid to do this. It could be just a stipend or whatever it is. So that means their duty is to attend clinics. Their duty is to liaise.
Dr. Adeyemi, sorry, I actually meant in the university system, in the teaching hospitals, to improve collaboration. Okay. Collaboration, since there's a kind of disconnect between surgeons and yes.
Okay, yes, I think it's still up to Smile Train. They've been the one doing it. So I think workshops, training, and all those things are just things that they will have to continue to do. I remember years ago, they were in Nigeria. There were quite a number of trainings that we had, and that got us setting up. But nowadays, again, I'm not sure it's like before again. So I think it's just that continuous awareness, training every year, workshops, virtual presence, and all that. And over time, people will be able to adjust again.
Thank you. Thank you very much. I don't think there are any other questions. In the comment in the chat box, You have some comments from Jesu Marie. So much interesting presentation. Thank you.